and introduce our speaker for today. So many of you may know Caroline Contillo is the Bureau of Emergency Preparedness and Response's lead trainer, providing disaster mental health and psychological first aid trainings for the Office of Mental Health's disaster response teams. She holds an MSW and an MS in disaster resilience from Tulane School of Social Work and previously worked at the Institute for Disaster Mental Health, designing training curriculum. Caroline specializes in disaster mental health, the collective trauma of disasters, and crisis intervention. We are absolutely in for a treat with Caroline's expertise, and so I am going to turn things over to her. And again, kindly ask that everyone mute themselves, and please use the chat and we will respond to your questions by the end of at the end of the presentation. So thank you, Caroline.
Thank you, Latifa. I see some familiar names and faces today, so great to see you if we've already met, and if not, great to meet you. I joined the Office of Mental Health Bureau of Emergency Preparedness and Response in February, and I've been leading our psychological first aid and disaster mental health trainings, so I may have met you there. I'm excited to present today. We're going to talk about what it's like to do this kind of psychological first aid and disaster mental health response with one of our vulnerable populations. And if you've been in one of my trainings, you know we talk about vulnerability as this way that some groups can experience more negative impacts from disasters. So people with serious mental illness, children and adolescents with serious emotional disturbance are in that kind of group of that we would consider vulnerable populations. So we'll talk about what makes these folks vulnerable and what we can do about it when we're thinking about doing psychological first aid with them and doing disaster mental health support. What are some ways that we might have to tailor it to support them? So yeah, I'm going to get into it. Oh, I wanted to say, because I usually do in-person trainings, but when I do online trainings, I like to say, take 1 second to do for yourself one thing that might make you a little bit more comfortable for the next hour. For me, that's going to mean moving my foot support. It's like a little bit high. I'm going to adjust it down. But being comfortable, it's not always comfortable to be on screens all day, but being as comfortable as we can be can help with taking in information. And there's going to be a lot of information in this training. So yeah, just doing that thing to adjust for comfort, and then we'll get started. Okay, so today's objectives, we're going to learn about the unique needs of individuals with serious mental illness, which I'll call SMI from now on, and children and adolescents with serious emotional disturbance, which I'll call SED, during and after disasters and other crises. We'll consider the obstacles faced by these populations and their caregivers. And we'll talk about how to tailor PFA and DMH response, psychological first aid and disaster mental health, for these populations. That's what we'll be doing today. So many of you might know, but just to talk a little bit about what we mean when we say serious mental illness, SMI. So this refers to a mental, behavioral, or emotional disorder resulting in serious functional impairment. So this can be a diagnosis of schizophrenia or related psychotic disorders. It might be bipolar affective disorder, autism. It could be severe forms of major depression, an OCD diagnosis, and a panic disorder. But importantly, not everyone who has a diagnosis would be considered a person with SMI. There needs to be a functional impairment. So we think about these impairments in social, academic, or occupational, and daily living activities. So again, a person might have a diagnosis of something, of this nature, but really unless it's impairing their daily function to the point that they really need functional support, it wouldn't be considered SMI. So you may, in the course of your work, interact with people who, if you're working at one of the OMH PCs or something like that, you may, through the nature of your job, be working with clients who have SMI. Or it might be the case that on one of these deployments where you go to someplace like a shelter or you go to someplace like a disaster recovery center, that's where you may be interacting with people who have one of these disorders that is impairing their function. So SED, what is serious emotional disturbance? A quick way to distinguish between the two is that SED is used for children and adolescents, so under the age of 18. There are some diagnoses you can't even make until a person is over the age of 18. So for SED, we're thinking about a fear, anxiety, or other emotionally based condition that results in, what would get called maladaptive behavior, specifically for children and young adults. This adversely affects their academic and social functioning, and this is where it would really distinguish between, a child who you might even have a diagnosis, but is it impacting their academic and social functioning? So this behavior can range from withdrawal and isolation to acting out and aggression, things you might see in classrooms. So a condition is considered SED when it's long-standing. So not just an episodic, response to a trauma that the child has had, but it's long-standing and prevents a child from forming satisfactory relationships with teachers and peers. So you can see that, the idea of it impacting academic and social functioning, teachers and peers, it's really impacting a child's ability to be in school and learn is where we might see some of this show up. So after a disaster or another kind of crisis, children with SED and their caregivers, because we kind of think about the whole family system when we're thinking about SED, and we'll talk about this more. This is where it can show up. So from now on, I'll say SMI and SED to respond or to refer to these. So in both SMI and SED, the presence of the mental illness or emotional disturbance alone is not what makes it SMI or SED. It's that significant impairment that requires a lot of support. So individuals in these populations will often have long-standing relationships to treatment for their condition because there is so much impairment involved when we're talking about SMI, SED. Often the people who have SMI, SED will have these long-standing relationships with support, providers, maybe peer support, medication. So you can already see how when a disaster happens and some of these things are interrupted, a person might need extra support from you. So not everyone you encounter who experiences SMI or SED will be in treatment. So that's another thing that might show up at something like an evacuation shelter. You might be witnessing somebody who is having symptoms to the level that it may be disruptive in the shelter, something like that. But they might not have a diagnosis. So we're not always going to be able to go off of diagnosis when we're responding to a disaster. We'll talk a little bit more about that too. So vulnerability, I mentioned that people experiencing SMI and SED are considered a vulnerable population. So to talk a little bit about what we mean, and in our trainings we do talk about this, that vulnerable populations refer to people who are at greater risk of poor physical and social health or greater adverse reactions to a disaster also. So for disasters, we would think about vulnerable populations as elderly folks, children, sometimes LGBTQ populations. I want to be careful to mention that it doesn't mean that the vulnerability is located in the person. It's in how much support they are able to receive in the wake of a disaster. So their vulnerability is the result of disparities in physical, economic, and social health status. Vulnerable populations are more likely to be adversely affected during disaster events. For a lot of reasons, but especially that they may be less able to anticipate and recover from hazards. So we'll talk a little bit about that and what we can do about it as well. But I think really importantly, when we're talking about vulnerable populations, we're thinking about what kind of support does this person need? We don't want to stereotype people and say, because you're of this population, you'll definitely need more support. But we can definitely see how people who have a disorder that's impairing their ability to function, who might require a lot of support from services, networks of caregivers, and support through medication, that in a disaster, that's potentially going to be really disrupted. So really just thinking about not kind of stereotyping people and stigmatizing them. We'll talk a little bit about stigma or making assumptions about their support needs, but coming into our PFA or disaster mental health support, knowing that we might want to assess for what services have been disrupted, who can we connect this person with, and things like that. So we'll talk a little bit about what specifically makes people with SMI and SED more vulnerable during and after a disaster. And a big one is isolation from social support. So in PFA, we talk about how one of the most research-backed ways to support somebody after a disaster is connection, whether that's connection with you or connection with their existing support network. Social support and the perception of social support is really important for everyone. And even more important for people with SMI and SED because they may already be experiencing isolation from social support. They're more likely to be living alone or with unrelated adults. So, again, some of you may be working with folks with SMI and SED in the context of one of OMH's psychiatric facilities, but some people are living with unrelated adults in a group home. Some are living alone, aren't able to have roommates because of the nature of their disorder. But in all of these cases, it can make social support feel really difficult on a good day, let alone during a disaster. They're also more likely to depend on services that can be disrupted by a disaster. If you think about something like a hurricane that might cut off somebody's access to providers, caregivers, access to medication, this can really throw somebody's management of their disorder into disarray. And then during a disaster, they may feel further isolated from any community that they do have access to. Peer support is a big thing, and any other support that they might need during an emergency and a disaster. So during a disaster, a person with SMI or SED and their family might have more need at a time when there are less resources. So vulnerable populations overall get less priority usually in disaster planning. This is why I talk in our DMH fundamentals class about how important it is to include everyone in disaster planning. Not many of you are probably on the disaster planning side of things, but if you are thinking about how do I include representatives for these populations, if not people from the populations themselves, like folks with SMI and SED, that lived experience, or people with disabilities, so that they can be part of the planning and not be left out in that response. But this ends up with people needing more support at a time when resources are less available or disrupted. And I think we've all probably had some experience with the way that agencies responsible for reestablishing care and support can already be stretched thin during regular times. And then during a disaster, when that need skyrockets, there can be less support. So these are just some of the ways that, unfortunately, and I think less so as time goes on, because I think people are recognizing the importance of really including everyone in disaster planning. But traditionally, support for people with SMI and SED can fall through the cracks, which is one of those reasons why it's so important when we think about having these disaster response teams and our county teams. You are the people who know what the resources in the community are, and you can fill in those gaps, at least temporarily, before making more connections and doing those warm handoffs that we'll talk about in a little bit. So interruption in resources and care. A lot of folks with SMI and SED will rely on things like libraries, drop-in centers, houses of worship, for things like hygiene, and just to connect with another person, maybe get a meal. Especially if they're experiencing something like houselessness. So when these things close, they're not left with a lot of options. Peer support services and access to medication may be disrupted, and providers might be difficult to contact or access. So people with SMI often experience comorbid disorders, like cardiovascular disorders, metabolic and respiratory illness at a higher rate than the general population. So what this could look like is somebody who has schizophrenia and diabetes. There's a lot that goes into this relationship. Sometimes it's medication-based, sometimes it's not, but that mind-body connection can be at play. But what this means is that somebody who has both the symptoms of their SMI and then also potentially cardiovascular, metabolic, or respiratory illness, both could be exacerbated by the interruptions, and that's kind of exponentially making things harder for somebody, especially when they don't have access to their routines. There's unplanned changes, and they might have a lack of access to medication, which we'll talk about in a little bit. And then psychological vulnerabilities because of the nature of SMI and SED. Changes in routines can create challenges for people. Routines can really be the structure people need to manage their symptoms. And when a disaster happens and those changes occur, that can be challenging. The nature of the disorder can make taking in rapid information about environmental changes can make that difficult. And then all of that added stress and chaos from the disaster can be difficult to cope with. So people with SMI and SED are also vulnerable to being misinformed. People might overlook their communication needs or overlook their need for information, period. And I think sometimes the nature of how caregivers can interact with people with SMI and SED, they might not be getting all of the information they need, which can make it really hard to respond and take care of themselves effectively during a disaster. So that said, these are all the things that will make responding to a disaster more challenging for folks in these groups. But I also want to mention, because we are going to talk a little bit about stigma also, that there is tons of evidence that people with SMI and SED have the same capacity to be resilient as everyone else. They have the same basic needs as everyone else during a disaster. We are going to talk about tailoring PFA to their specific needs, but in general, you can think about these same needs for connectedness, safety, efficacy, and they can show just as much of this capacity to rise to the occasion and act heroically during a disaster. I read some case studies of people living in psychiatric facilities and group homes after things like hurricanes, and that sense that sometimes living through a stressful situation together can bond people, and they can get a sense of that, the same sense of social support and connection as anyone else. That's at play too. So we just want to make sure we hold the door open to resilience for everyone, despite the effect that their disorder and maybe some of the symptom exacerbation might have on them. And related to that, just talking about stigma and marginalization, that these are things that people with SMI and SED deal with. People making assumptions about their capacity, people making, discrimination, things like that, that can happen in regular times. And then during a disaster, this can make it more challenging for them to receive care. So they may experience stigma. This may increase after a disaster. There are systemic barriers and discrimination that can limit their access to services and supports. Disasters can amplify existing inequities in healthcare, housing, and other supports. This happens with vulnerable populations across the board. This happens with things like systemic racism, where after a disaster, these inequities can get worse. So this marginalization includes exclusion from planning. I talked a little bit about that, the way people can get left out of planning. It can also lead to discrimination in shelters. And I don't think this is in the end of the presentation, and I think I just was going to make a point to mention this, that this is a place where you might be able to help. That if you're at something like an evacuation shelter, somebody with SMI is having some symptom exacerbation, is maybe being loud, maybe talking to people that other people can't see, things like that. This person can experience discrimination because of that, and they can experience that stigma. So this may be a place where you, as a person providing PFA and disaster mental health support. You may be able to provide psychoeducation to shelter staff and maybe some of the other people on the ground in the shelter. This might be a place where you can advocate. Is there a place to give this person privacy and maybe some protection from people who might be, you know, not happy that they're there? But these are the kinds of things that can show up when a person is, you know, in a general population after disaster when tensions are high. And then in terms of cultural competence, so we talk about cultural competence in our trainings. We talk about this sense that part of our work in providing PFA and disaster mental health support is understanding how other people might be experiencing the world different than we do. And we want to, because PFA and disaster mental health work is not clinical and you are not providing treatment for people, even a person who has SMI, and you might know that, you know, depending on what somebody's diagnosis is, you might know about the treatment for that particular disorder. But when we're providing this kind of support, there's a sense that we don't want to forget everything that we know, but we also want to be coming from this person to person perspective, which means to some extent respecting people's lived experience without pathologizing. So we're not turning people into their disorder when we're interacting with them. Since so much of this work is about really providing that connection and quality of our presence, if we're operating through this lens of I know exactly what disorder this person has, and maybe you do, maybe you've worked with them before and you know what their diagnosis is, but when we're providing this post-disaster or during a disaster kind of support, people can feel it when we're interacting with them through that filter. So as much as possible, being curious about their lived experience, even when their disorder might make it so that it's so much different than how we would be experiencing this. And we want to acknowledge cultural expressions of mental health and distress. People and their caregivers may have cultural understandings of what this person is experiencing. For instance, when there are voices that are not there, or people that you know, other people might not be able to see, we may have a very clinical and diagnostic understanding of what that means. But especially when we're working with, you know, children and their entire family system, there may be cultural understandings of that we don't, in this context, need to be, you know, immediately shooting down in favor of our diagnostic perspective. We want to adapt our communication for differing needs according to various diagnoses or expressions. So, yeah, that just means we're always doing this work trying to attune to where people are at and what their needs are, and making sure people can understand things. A person's disorder might make that more complex, but we want to give ourselves and we want to give them the time to understand what their communication needs are. We want to avoid assumptions about capacity and compliance. We might have some assumptions based on somebody's expression of their disorder about, you know, whether or not they're going to listen to others. If there's, for instance, rules at a shelter or something like that, what their capacity is to take in information, things like that. And again, if you've worked with somebody over time and this is at your place of work that you're interacting with somebody, that might be different. But if we're showing up after a disaster to a disaster recovery center or something like that, just as much as possible, avoiding the assumptions in the same way that we would want to avoid assumptions working with any cultural background or group. And always, and we'll talk about this in the PFA section, prioritizing dignity and choice, just always allowing people their dignity, and when possible, collaborating with them on being able to make choices. And of course, there are times when a person, the nature of somebody's disorder might mean that we need to be a bit more directive, but as much as possible, working in collaboration with people. I also wanted to mention this about PTSD, that people with SMI and SED, the research shows, experience a higher rate of trauma exposure than the general public. And some research shows up to 90% of people with an SMI diagnosis have comorbid trauma exposure. So PTSD is often underdiagnosed and undertreated in people who are in treatment for SMI and SED. This can have, there's a lot of reasons behind this. This could be because trauma symptoms may be misattributed to a primary diagnosis. I'm mentioning it here because I think this means it's important for us to have a trauma-informed perspective when we're working with people with SMI and SED, even if we don't necessarily know that they have PTSD or had a trauma exposure. The research shows that using a trauma-informed lens when we interact with them, we can see that with up to 90% of folks with SMI having this trauma exposure, it can be helpful. So I'll talk a little bit about what a trauma-informed lens means. It is, if you've ever done a trauma-informed care training, it is very similar to PFA, but I'll get into that towards the end as well. And now we'll talk about, so how do we tailor PFA when working with these populations? So PFA, again, that's psychological first aid. I'm assuming most of you, if not all of you, have had that psychological first aid training. And so if you remember, when we're doing psychological first aid, we are triaging for immediate needs. So what are people's most immediate and basic needs? How can we help them? Whether they're emotional needs, practical needs, etc. We're still doing that here. We're still not in the practice of diagnosing or providing treatment for disorders. We may be aware that somebody has a disorder and be making connections in the same way that we would with anyone with psychological first aid. But here are a few ways that you can, just some extra things to think about if you're working with somebody with SMI or a family with children with SED. And the first thing is that beginning, that contact and engagement. How do you start? And I just always want to emphasize that quality of presence. So bringing your non-judgmental presence. And you might be a professional who has a background of working with people with a specific disorder. You may have a lot of knowledge about working with people in treatment with certain disorders. This is a little bit of a practice, again, not of forgetting everything that you know, but you are taking off the clinician hat and stepping into that disaster response fundamentals perspective, that psychological first aid perspective, which starts with that non-judgment and that just greeting somebody person to person. And that includes being aware of any possible, we talk a lot about power dynamics in the trainings. What is that power dynamic that somebody might experience with you as either, maybe you're somebody they do know as a clinician, maybe you are somebody who they know as a representative of the Office of Mental Health doing disaster mental health work. So just being aware of what that power dynamic does to a person's ability to trust you and how they might work with you. How do you work with that mistrust? I think it goes back to that first bullet point, bringing your non-judgmental presence, your curiosity. When you're in treatment with someone, you may have, you have knowledge of protocols and steps to take. This is a context where you might be a little bit more open to curiosity about somebody's experience and just being able to provide your presence as a support. So that also includes being aware of their trauma triggers. You might already know about them. This is another place where we don't want to hold ourselves to an unfair standard of perfection with ourselves, where that makes us kind of unable to engage with somebody if we're really worried about triggering them. But just understanding that, again, with 90% of the population of folks with SMI having that trauma exposure, there are things that might trigger them that you couldn't anticipate. But if you're noticing that that's happening, applying the same rupture and repair principles that we would with anyone else. So how do you then be with them and reestablish that connection? Maybe that takes a little bit of time, but just being aware that that can happen. Safety and comfort. Another thing that's really important with everyone after a disaster, but just being really aware of and working with this importance of helping identify what they need to feel safe. You might have some ideas about that, but part of how you can build this rapport and connection is working with them identifying what do you need to feel safe and being mindful of overstimulation. So we'll talk a little bit about this when we talk about sensory needs, but that overstimulation, it's something that will present itself during or after a disaster or crisis. There are sights, there are sounds, there is a potential intensity of what's going on and urgency that everyone is susceptible to getting impacted by, but people who have um, uh, people with SMI and SED, that overstimulation can be really destabilizing. So being aware of that, how can we create safety and comfort? Maybe this again means advocating for a lower stimulation zone in a shelter, creating a place of privacy, creating ways to um, uh, help work with some of that stimulation. So stabilization and coping. If a person seems distressed or disoriented, you're using grounding techniques instead of confrontation. That might seem obvious, but sometimes if a person's symptoms are expressing in a certain way, including agitation and things like that, we're always talking in PFA about what we do to stay grounded and centered so that we're not getting kind of brought into someone's activation. That's just especially important here. So when a person is in distress or disoriented, maybe there's some symptom exacerbation, thinking about grounding techniques. They might not be open to it, it might not be helpful, but if it is, you're thinking about things like sitting and taking some breaths, maybe something sensory, that kind of looking around the room and noticing, things you can see, smell, taste, and touch, but not making assumptions about people's coping capacity based on their symptoms. Again, this is something that when we're not in a clinical or a therapeutic situation and we don't have our worksheets to do with somebody or something like that, it can feel very vulnerable for us as practitioners to just be person to person, especially if somebody's expression of their disorder is challenging. But as much as possible, we're not making assumptions about their coping capacity based on those symptoms. They may be able to do more than you and other people are making assumptions about. So information gathering, this is a great way that you could be of support. So there's lots of ways in PFA and disaster mental health that we talk about being able to problem solve with people and things like that. But you are always thinking about what are pre-existing supports? Where can you reestablish continuity of care? Who would they normally be in touch with? Who are the providers? Peer support, things like that. And then just be mindful that there may be processing delays. It may take a minute for a person to remember or come to or find this information within themselves or remember who to talk to. So just being really patient, staying grounded yourself and regulated, but really being curious about what are those pre-existing supports? Do they have any kind of advanced directive? Is there already a network of support set up that you just need to find out about that you can put them in touch with? And so related to that, you can help them navigate these service disruptions, housing stability, medication access. We'll have a whole slide on medication in a bit, but also linking with peer advocates if possible. A lot of people with SMI and SED will rely on peer support networks for help. So that can be a great way to get in touch with people who might be able to help, especially if they aren't in the immediate area and weren't affected by the disaster as directly. And yeah, connecting with the support network. This is all very interrelated. So exploring safe, trusted relationships with service providers and peer support, and sometimes even sitting with somebody and kind of going through that process of remembering who are these safe relationships can have a regulating effect. And knowing that, reassuring that you're going to be able to get in touch with them at some point, even if you can't right now. So that might be a lot of the work that you're doing, is just being curious, investigating, taking notes on what that support network is, and reassuring somebody that, people are working on getting services back up, and things like that. So yeah, medication continuity. This can be a big challenge. And as I mentioned, with people with SMI, you're not just thinking about their psychiatric medication, that they may have a number of comorbid physical illnesses. So assessing immediate medication needs. Sometimes people have an emergency supply. Sometimes it will be easy to get in touch with a provider. But that can be one of the first things that when you're in that problem solving stage with somebody, after you've thought about that, kind of meeting them and stabilizing and getting grounded, thinking about, okay, is there medication that we're going to need to find and get somebody reconnected with? So this can look like coordinating with, and again, like you would talk to your shift supervisor about this and not be expected to do this on your own, but just so you know, thinking about coordinating with local pharmacies. There might be prescribing clinics, there might be mental health providers either on site or that your shift supervisor or Office of Mental Health knows about to be able to put you in touch with. Also, at a place like a Red Cross shelter, Red Cross often has a prescribing doctor on site. And then there are things, many areas have mobile medical or psychiatric units who might be involved. And again, you wouldn't be expected to, as an individual, be aware of what all these things are in the moment during a deployment, but just to know these are things that you can ask your shift supervisor about, that Office of Mental Health would be, you know, in partnership with these other organizations doing work to get medication back up and running as soon as possible. And then when there's something like a federal declaration and when FEMA is involved, additional services may be available at something like a disaster recovery center. So you won't be completely on your own, but depending on the nature of a disaster, medication can be harder sometimes to get immediate access to. So this is something where you want to work with the individual to understand what their medication needs are, who the people in their life are that are providers who you might be able to get in touch with, but also to be aware of some of these other resources. And then beyond medication, people with SMI and SED often rely on a whole network of services and providers. So in the same way that you're assessing medication needs, assessing other immediate service disruptions. So what other kinds of care and support does this person turn to that may have been disrupted by the disaster? And then there's an approach of, are you reconnecting them with the version that they were already in support by? Or are there ways that you might be able to recreate some of the support in the space? Are there people in the space who can support them? Either way, you're validating their needs, always validating thoughts and feelings and needs, and just taking notes. All of this can be pretty complex. So taking notes on what you hear from the person and then what you're understanding in the space from any providers who are available, facilitating the referrals and warm handoffs. We always talk in PFA about not leaving people in a state of distress. We want to, and we also don't want to just like push them. We're done. Good luck getting in contact with that person. Whenever we can facilitate the referral or we can facilitate the warm handoff, doing that so that each person on either side of it, the person with SMI and the provider, or whoever you're connecting with them, maybe a peer, they both get introduced. They have you to facilitate that connection so that it's not too jarring. Because again, when we're doing this work, there's a sense that we're emotional shock absorbers. So anything we can do to make these connections easier for people is going to be really supportive of their mental health. So during disasters, sometimes case management resources are made available, and there's always peer support. So these are forms of support that can be very helpful, and for you to just be aware that this is something to ask on the ground about what's available. And then we're always asking you to be flexible. Your flexibility and your ability to roll with the way that things change fast, especially when you're working with somebody who that can be really distressing for them. If you are able to handle that gracefully and groundedly, that's going to help this person feel supported. And then we'll talk about what trauma-informed care principles are. So trauma-informed care, it's similar to psychological first aid. We always talk about how with psychological first aid, um, it's not exactly an intervention, it's more of a perspective or a toolkit that we can use, and that we use it with everyone. Trauma-informed care is similar. This is a perspective on how to interact with people in a way that takes into consideration that people may have had trauma exposure, they may have PTSD that we don't know about, or maybe it's not to that clinical level, but that they have had exposure to trauma, and that might be shaping how they are able to interact with you and how they experience the world. So you don't need a diagnosis of PTSD to benefit from trauma-informed care. This is something where, again, if we are understanding that people with SMI 90% of the time, up to 90% of the time, may have had that trauma exposure, it can be helpful to think in terms of this. And you'll hear some overlap with psychological first aid, but I just wanted to include this as well. So safety, bringing people a sense of safety, and that is that physical, emotional, and psychological safety. And so similar to how we talk about that psychological safety in psychological first aid, um, it's not the absence of risk, it's the presence of social support. So you are being that social support, but you're also, we talked about all of those different ways to kind of assess and connect people with that whole network of social support that they might already have. And then if you're interacting with somebody who maybe they don't have a lot of support, could this be that opportunity to consider not just their psychological safety needs and their emotional needs, but some of these other uh, actual physical needs that they have? For instance, like I mentioned, if they're at a shelter or something like that, um, uh, that they may actually need some support in feeling physically safe in the space. Trustworthiness and transparency, clear as kind, is this sense that we want to be building trust with people by being transparent. So this can mean simply walking somebody through what we're doing with them and what our intention is and what we're doing there. Being as above board and transparent about that and using accessible language can be really helpful in terms of building that trust that can be so important for people with SMI and families and caretakers and children with SED. I mentioned this before, but peer support is another really great way to find support. And if you can in your work, including people with lived experience in the planning and response when possible. So more and more, I think peer support is understanding that a lot of people do have lived experience of mental illness. Maybe it doesn't rise to that level of SMI, but having people who understand and can provide that peer support involved in some way can be really helpful. Collaboration and mutuality, this idea of working with somebody to co-create next steps. So in PFA, we talk about this in terms of like listening for needs and saying back to somebody, I heard you say you want to do this, and I heard you say you want to do this. Which one feels more important right now? We can use that here as well. And again, we might need to be more directive with somebody based on the nature of their disorder. But for the most part, we are still always including people in the decision making, especially because we are not the people doing treatment with this person. We're providing this post-disaster support and response. And then empowerment, emphasizing choice and resilience. This is kind of that strengths-based approach of not just focusing on, oh, what are the things that are going to make this disaster more challenging for somebody, but what are the sources of resilience that they have in their life, and maybe where have they already been resilient? So that strengths-based approach and emphasizing choice, always giving choices that they do have choices, even when it's small, even when we're saying, do you want a soda or a lemonade? These are small choices that are trauma informed and giving people a sense of agency, which can be really helpful with some of the dysregulation that comes up during the stress of a disaster. So everything I've mentioned can be helpful for both SMI and SED, but I did want to talk about some things that are going to be specific to children with serious emotional disturbance and their family system. For instance, we are really focusing on that whole family system, including caregiver well-being. The caregivers are potentially going to be, they may already be experiencing stress from having to help the family cope with SED. The disaster is going to add to that. So really emphasizing caregiver well-being in addition to support of the child with SED. Ensuring developmentally appropriate communication and understanding that this could be different for a child with SED. So really attuning to what are the communication needs of the child and the family and being able to work from there. Predictability is very important. So we've talked about the importance of routines and things like that. Being able to make things as predictable as possible, which can sound frustrating in a situation where we're also asking you to expect the unexpected. But in whatever way you can, providing some predictability, using a strengths-based approach, I just mentioned that, but focusing on strengths with children just becomes so important that focusing on just the deficits and the challenges can make things feel a lot harder for the family, especially during a disaster. And then we'll talk a little bit about sensory sensitivities as well. And this can be important for children and adults with autism, but it can also be important for children with a variety of experiences. So we'll talk about what to do about that. So caregiver stress, even under non-emergency conditions, these caregivers are going to be experiencing heightened stress, and then the disasters amplify those stressors, and children are taking their emotional cues from the adults in their life. So that's something that comes up, after a disaster. Children are looking to their parents to see, should I be more nervous about this? Should I be less nervous? And if the parents are being stressed out by the child's behavior and the disaster, this can create kind of a feedback. So caregiver well-being is directly going to impact outcomes for children. So that any support strategies that you are brainstorming and helping them connect with need to be family-centered and include co-regulation. So I'll talk a little bit about co-regulation. I just loved this image where their storm meets our calm, co-regulation occurs. Co-regulation is this way that our nervous systems are always speaking to each other. And, we think about the idea that an emotion can be contagious. If we are able to maintain a calm, grounded presence, that is contagious as well. So when you're thinking about a whole family that is dealing with, a child who needs predictability and grounding to manage their SED symptoms, facing a disaster, which could feel very stormy, we can provide that co-regulation through our own groundedness and through doing some grounding exercises together. And then you're also modeling for the parent that this is something they can do with the child, that they are affecting each other, and that this co-regulation, while difficult when a child might have some real emotional sensitivities, as much as possible, we can all be contributing to this regulation. So how do we do that? You trying to model that calm presence, offering simple, repeatable structures of rest, movement, meals, and connection. How can you make them regular? How can you make them rhythmic? How can you make them a pattern? Helping them do that, supporting them do that is going to help. Asking about what routines they already have and helping families reestablish them or even create new ones in this new context. Validating caregiver efforts by celebrating small wins. So again, you're not just hyper-focusing on the child and helping them celebrate small wins, but really validating the caregiver as well in the whole family system. Identifying next steps, even if they're very small, this can be really helpful. And just understanding the way that predictability builds emotional safety. This disaster might be an opportunity. Even while being very stressful, it can be an opportunity for a family to learn about these things. So you might, for the first time, be offering them some information about using predictability to build emotional safety, celebrating small wins, establishing new routines. This could be an opportunity for more connection to happen, which can be supportive of the child and the whole family system. And then support for sensory needs, identifying what is overwhelming to a child or adolescent, or honestly an adult. I find this helpful, identifying what is overwhelming: noise, crowds, lights, and then creating quiet zones or sensory friendly spaces. So again, in a place like a shelter, this could involve hanging a sheet just to create some privacy, but also use of tools like noise canceling headphones, sunglasses, fidget toys, weighted blankets. If it's possible for your team to have those things on hand, that could be really helpful. Or just reminding people, if that's something that they have, is this something that they want to use? Giving support for breaks and calming activities, always encouraging those, and helping caregivers notice signs of sensory overload before escalation. So knowing there might how might somebody be acting that shows a sign that they're headed towards overload. Can you get in with some of these sensory friendly things before it gets to that point, and maybe develop an understanding of how that happens? Okay, so that is the content of this presentation. Let's open it up for, I think we've got a few minutes for questions, if anybody has any questions. And I don't have the chat open, so if one of my colleagues, if there's anybody in the chat, let me know.
We have responded to the questions that have come in thus far, but again, we do have a few minutes. If anybody has questions or comments for Caroline, feel free to unmute yourself. Thank you.
I think just because there's some people who might be on the phone, we should say this will be available. There will be a link online so they can see this whole presentation going forward. Because we did get questions about, was it going to be available? And the answer is yes. So we should push the record button. We can probably turn that off. I guess. No, let's leave it on until we see.
Okay.
Anybody else have questions or comments or thoughts?
Well, yeah, I hope this was helpful. If you do have any questions that you don't want to, mention in front of everyone else in the meeting right now, that's our email address. That's our general email box. I'll also mention my email address, caroline.cantillo@omh.ny.gov. I'll drop that in the chat. You can email me directly, because we really want you to feel supported in doing this work. So anything we can do to help, yeah, let me know. Thanks so much.
So again, thank you. And Caroline, you don't have the chat open, but we're getting lots of thank you for the helpful information. Someone mentioned they didn't realize that autism was SMI, so certainly a learning opportunity. And lots of thank yous. So there are comments here. And I'm putting Caroline's email in the chat.
Thank you.
I always love it when the pictures come up too, so don't be afraid to put your cameras back on.
Yeah, great to